Good morning, everyone, or good afternoon, depending on where you are joining us from in the world. Welcome to our inaugural international seminar series for the Florence Nightingale Faculty of Nursing, Midwifery and Palliative Care. And it's my great pleasure to be chairing the seminar this morning. So just a few words about the faculty. We are a global leader in healthcare research and education, committed to advancing knowledge and improving patient outcomes. We are really proud to be ranked #1 globally in nursing for our work on the QS World Rankings. Our faculty is organised into 4 research divisions. So as you can see, we have care of long-term conditions, and a number of the presentations this morning are about long-term conditions. In fact, they all are. So I'm very proud as head of division for care in long-term conditions to be chairing this particular seminar. Other divisions are the Digital Health and Applied Technology Assessment Research Division, Methodologies, and the Cicely Saunders Institute. And all of our divisions are, the heads of these divisions are world-leading experts and senior professors in their field. We have an active and vibrant postgraduate research programme currently we have 110 post-PGR students in the faculty, all studying for their PhDs. And we enjoy very much the energy and the new ideas and innovation that these students bring to our community. There are many ways in which our PGR students receive their PhD funding, and academics across the faculty support prospective candidates in helping them identify and secure funding. We have our own PGR faculty funded scholarship. The current round has just closed, so we're excited to see the applications, review the applications that have just recently come in. But to give you a good heads up, there will be another scholarship round next year in 2026. It will open in mid-January, close at the end of March. And we invite applications from nurses in nursing, midwifery and in palliative care to apply for that. And if you want to work with one of our academics, I really urge you to look at our web pages. Under those divisions, find the academics that are offering the sorts of supervision and expertise that you're interested in studying under, and then make contact with that person, with that professor or that lecturer, senior lecturer or reader. So today's schedule, we've got 3 really exciting presentations from esteemed colleagues who are going to be talking about their work in end-of-life dementia and in diabetes. And I'll let them introduce themselves as we go through the presentation. But here's just a little heads up of the topics. And just finally, before we start, to advertise our upcoming postgraduate webinars and seminars. Some of these are about our postgraduate taught courses that we offer. And you can see the dates for that. If you click on the QR code, it will enable you to sign up for these webinars. The later one in May is postgraduate research webinar, thinking about application and what makes a good application for a PhD program. And then in June, we have another research seminar like this with 2 different topics. So really excited about this international seminar series and hope you are too. So without further ado, I'm going to stop sharing my screen and allow my colleague, Dr. Ellis Smith, to start to share her screen, and we'll take away her topic for this morning. If you want to write some questions while that screen sharing is happening, please put questions into the chat. We've muted your microphones and your cameras, and they can be unmuted if you want to ask your own questions, but please use the chat for questions.
Thank you so much for the opportunity to present to you today. My name is Clare Ellis Smith. I'm a senior lecturer at Cicely Saunders Institute of Palliative Care Policy and Rehabilitation. I'm really delighted to present to you the hot off the press, really new findings of a study that's just recently closed called the Empowering Better End of Life Dementia Care project. And this is the feasibility and process evaluation of that project. Delighted to present this to you. I would like to start by just thanking everybody involved in the project. It's been huge, a lot of contributors. So I would like to acknowledge everybody's been involved, and also the funders, ESRC and the National Institute for Health Research, who funded the project. I'm going to start by just talking about some of the palliative care symptoms and concerns that individuals with dementia experience. This is some work that we conducted some years ago, looking at symptoms and concerns that individuals with dementia experience. And this is a population of really mild dementia to very advanced dementia, but actually the majority of the population here had mild dementia. And I just want to highlight that the symptoms and concerns experienced by this population, really kind of a lot of physical symptoms, particularly around appetite, weakness, poor mobility, and problems communicating. So the green is slight and the red overwhelming. But when we move to psychosocial concerns, this becomes far more pronounced, and really, really high prevalence of sometimes quite overwhelming psychosocial symptoms experienced by people with dementia. And the dementia trajectory is also uncertain. So people live with dementia sometimes for very many years with a lot of fluctuation in their symptoms. They may have periods of decline, they may improve a little bit, but a long period of increasingly progressive dementia, and with that, managing uncertainty with regards to physical symptoms, psychosocial symptoms, social concerns, and practical concerns, and continual change. And where we're trying to balance kind of maximizing ability to function, but also maximizing quality of life and reducing symptoms during that time. So when does palliative care benefit individuals? Well, given we know that people with dementia experience symptoms and concerns throughout the trajectory, and they may have symptoms and concerns and palliative care needs throughout from the point of diagnosis, palliative care could benefit people throughout, not just at the end of life or when people are dying. And so we really need to think about approaches, so a needs-based approach to palliative care, when people can benefit from palliative care throughout the trajectory. So the Empowering Better End of Life Dementia Care Program really aimed to improve palliative care access to all those experiencing dementia, and particularly to look at developing a model of integrated palliative dementia care. So ensuring that people who need palliative care get palliative care at the right time. And to do this, we did a huge program of work, and I won't talk through all of it, but really kind of just to say that it was 6 work streams, all informing a co-design of a palliative dementia intervention to support integrated palliative dementia care in health and social care, so for people living at home and in community teams, and then to evaluate the intervention in a feasibility trial. And I'll touch on some of the findings from the co-design work, really presenting the intervention, and then focus today on the results of the feasibility and process evaluation that we conducted. So a huge amount of work went into developing the intervention based on all the work streams of the EMBED-Care program, so systematic review, cohort study, and routine data. And then we synthesized that data to develop and co-design the intervention with key stakeholders, including people with dementia, family carers, and health and social care practitioners. And these are some of the publications that come from developing the intervention. Based on all that work, we developed a program theory. I obviously won't go into that in any detail, but just to highlight that The program theory synthesized findings from all the work streams. So we've got blue, which came from the reviews, green, which came from co-design work, the purple came from our cohort study, and the orange came from all the phases of the EMBED-Care program. And you can see we've got a very thorough and comprehensive program theory which underpinned all our work. Based on that, the EMBED-Care Framework really comprises 4 key components. It comprises a comprehensive assessment, so holistic assessment of physical, psychosocial, and existential concerns experienced by people with dementia, and family concerns as well, and can be completed by the person. It can be completed by family members or both. This leads to evidence-based decision support tools and shared decision making. So based on the IPOS-DEM and decision support tools, people can make shared decision making and set priorities for what people's main concerns are. And this is delivered by via an app called the Attachaway app. So this is what the IPOS-DEM looks like. It's the main symptoms and concerns people experience, and it's easy and brief to complete. Linked to 12 decision support areas, and here's an example of one. So how you might further assess symptoms, understand the causes, and how best to manage these based on best evidence and best practice. And this is what the app looks like. And you can see that based on kind of people's scores, they get either an amber or a red alert showing how to prioritize symptoms and concerns. So in our study, we aim to explore the key mechanisms and likely outcomes and the acceptability and feasibility of the study, and develop the underpinning program theory, both understanding how it works and its implementation in community teams and care homes. It's informed by the MRC framework. So I think a lot of people are familiar with this, and also the MRC process evaluation, developing a logic model to explain the mechanisms, action, and outcomes. And it was also informed by program theory and normalization process theory, which is an implementation theory. It was conducted in 2 residential care homes and 2 community teams, and we recruited people with dementia, family carers, and staff. And it was a single-arm feasibility study where we actually implemented EMBED-Care Framework in routine care for all people with dementia in participating teams, not just those who were recruited, but we recruited people with dementia and family carers to participate for 12 weeks, and we collected data on them from them during that 12-week period. And we recruited health and social care practitioners throughout the period of the study to understand its implementation. And we used the app data to collect fully anonymous aggregated data on the intervention usage. We also did semi-structured interviews with family members and people with dementia, and focus groups and interviews with staff, and non-participant observations. We collected quite a lot of data for people with dementia, family carers, and staff at baseline 4, 8, and 12 weeks, and for staff at baseline 8 and 24 weeks. I'm not going to present this, so this is just to give you an idea of the data that we collected, but I won't go into it in much detail. And we conducted codebook analysis for our qualitative data and descriptive statistics for our quantitative data, and we analyzed these separately and integrated these at the interpretation phase. This is a little bit of the participants we recruited. We managed to follow up most, although some people with dementia were lost to follow up either due to withdrawal, sickness, or death. The mean age was 82. The majority were white British, the majority were female, and the majority had Alzheimer's disease. For family carers, the mean age was almost 67. They were all white British, predominantly female, predominantly child carers, and not living with the individual. Again, kind of most were followed up, but some were lost due to death or withdrawal. And for staff, the majority were female. The majority were very experienced, with over 10 years experience, mixed in terms of ethnicity, and generally kind of the loss of follow-up was due to staff sickness or annual leave. We did semi-structured interviews with people with dementia and family carers, and semi-structured interviews and focus group with staff. There were three main themes. The three themes were empowerment, streamlining, and communication. And in terms of empowerment, we really found that the EMBED-Care Framework empowered people with dementia. So a quote here says that it empowers people with dementia and family carers to have ownership of dementia and their care. They have control of their care and their own lives. And this family carer is saying, now I can identify what's up and what might be happening and how I might be able to deal with it. It empowered holistic person-centered care. So a staff member saying the assessment opened up a can of worms that we really wouldn't have picked up on otherwise. And also prioritizing the individual. It focused back on the gentleman himself, rather than going what the carers would perceive as a problem. And it also prioritized, enabled prioritization. So by using the EMBED-Care Framework and priority of care list, it gives guidance on what we approach and what's supposed to be prioritized. Streamlining was another main theme, and really how this was really about how the EMBED-Care fitted with existing processes. So some of the challenges was fitting with existing protocols. One care home had a very similar protocol, and it was struggling in terms of how to prioritize which protocol to use. So we got two protocols, and I don't want to get into trouble. I'd rather use the one that the care home procedure is using. Some care home staff found the app time consuming and didn't provide the response it needed, particularly when it was more of an emergency. So by the time they had responded to the app, they had already managed the situation. And leadership support was essential, so that they needed leaders to make time and support staff to use the intervention. It needed some flexibility in terms of the training and also usage, and flexibility also in terms of using the app. So sometimes it was easier for people with dementia and family carers to use a paper copy, whereas the staff were using the app and the digital version. So kind of one staff member's talking about they gave the paper version to people with dementia, but they completed it on the app, and that supported use. And finally, the EMBED-Care Framework supported communication. It supported family involvement and partnership. So this family carer is saying it was nice to be included and being able to be involved in a collective discussion with the staff. But it also promoted timely escalation and integrated care. So it was about, this staff member talking about, actually it identified a problem, but it also enabled escalation and referral to the falls team. So staff completing the EMBED-Care Framework said that the EMBED-Care and the IPOS-DEM supported discussion of the results before making any decision. And this was more pronounced in the community team, with 85% saying that versus 59% in the care home. Again, IPOS-DEM questionnaire supported this and use of decision support tools to support discussion. So most participants said that yes, it supports using the decision support tool, supported discussion and treatment options. And that was both in the care home and the community team. And the EMBED-Care Framework was helpful to understand concerns and determine priorities for care and treatments. This was both in the care home, but much more in the community team, which was 97% versus 86%. In terms of being normalized in parts of routine care, you can see that over time, from baseline in the blue to 8 weeks to 24 weeks, the EMBED-Care Framework became more familiar and felt more familiar and became more part of normal work. So during that process, it felt more like normal work and staff felt that it would become part of normal work. And this was both in the care homes and the community teams. So based on the findings, I'm nearly
Claire,
finished.
Okay.
Last slide.
Last slide. Great. Thank you.
Yeah, so based on that, we developed a logic model, and I'm just going to skip to kind of the conclusion. So in both teams, the EMBED-Care Framework supported holistic assessment, monitoring, and staff development and team communication. In the community teams, it supported greater understanding of individuals' needs and priorities, and also empowered family carers to manage teams. The EMBED-Care Framework was acceptable and its use was enhanced by ease of use in care, but in care homes, it was diminished by duplication in care processes. And implementation could be strengthened by interoperability of systems, reducing technical problems, and email alert functionality. And that's the end. So I'm going to stop sharing my screen.
Thank you, Claire. And please, that was a fascinating presentation and a large amount of work. Thank you very much for that great presentation. I can't see, everybody's been a little shy in the chat at the moment with their questions. So in the interest of time, I'm going to ask people, attendees, to please post some questions in the chat for Claire, and she will get back to you. She can reply during this during the seminar or afterwards. So please do ask Claire your questions, and we'll move on to our second presenter now, which is Dr. Kirsty Winkley, who's going to share her work on supporting people with type 2 diabetes to initiate insulin treatment. Kirsty, over to you. Thank you.
Thank you very much, Jackie. Can everybody see me and hear me and see the slides?
Yes, we can.
Yeah, okay, thank you very much. So my name is Kirsty Winkley and I'm a diabetes nurse, health psychologist and academic based at King's College London within the Care in Long-Term Conditions Research Division. My clinical role is almost exclusively supporting people with type 2 diabetes, and usually at a point of transition in their lives when intensification of therapy is often needed. And one of those transitions is starting insulin. So this presentation is going to cover that aspect of diabetes self-management. So an overview of the presentation. So I'm just going to go briefly through the natural history of type 2 diabetes, talk about clinical guidance for intensification of therapy, medication taking behavior, insulin and insulin beliefs, clinical inertia and psychoeducation for insulin, and then just a summary as well. So this slide shows us the natural history of type 2 diabetes, and what I want you to look at is actually this yellow line, so that we can see really from the onset of type 2 diabetes through diagnosis, although we initially get this increase in insulin secretion, we find over time, after a few years of type 2 diabetes duration, we get this lessening of the insulin secretion response from the beta cells. And this means that for many people with type 2 diabetes, insulin becomes a necessary part of treatment. So landmark studies such as the United Kingdom Prospective Diabetes Study have underscored how diabetes is now treated and managed. And the UK PDS demonstrated that intensive treatment of type 2 diabetes, which included insulin treatment, in addition to oral anti-diabetic agents, led to consistently lower HbA1c levels up to 15 years from initial randomization, compared with the group that received conventional oral treatment. So we can see this in this graph here. There was a 25% reduced risk in the risk of microvascular disease for the intensive group. However, in this second graph on the slide, UK PDS also highlights that some of insulin's associated problems, which is often the weight increase that's associated with starting insulin, can be a problem. So although we got this improvement in HbA1c for the intensive group, we also got the weight gain, which generally nobody wants to put on weight when they have diabetes. So I'm going to go now through some of the guidance that we use, clinical guidance. So we in the UK are guided by NICE in terms of pharmacological diabetes management. And this on balance corresponds with many international guidance, clinical guidance, especially when it comes to intensification with insulin. But in brief, for most people with diagnosed type 2 diabetes, as well as looking at their lifestyle and managing that and improving where they can, they will mainly be offered metformin or other oral agents if they are intolerant of metformin or have other comorbidities such as higher cardiovascular risk or chronic kidney disease. And then following that, there may be a first intensification of therapy. If their HbA1c rises and it's no longer at target, they will be offered another oral agent. And then at second intensification, they may be offered insulin treatment. For some people, the insulin may not be offered depending on their body mass index or perhaps their employment status. For example, if they are a lorry driver, for example, they would not be able to start insulin without stopping work. So this might mean that they would be offered an alternative therapy such as a GLP-1. However, it's important just to point out that the problem with some of the oral agents and some of the newer agents, such as the SGLT2s, is that their efficacy declines with the declining beta function. So your body needs to have some degree of insulin secretion for some of these other tablets to work. So let's talk about medication taking behavior. So the figures for type 2 diabetes studies seem to imply that people with type 2 diabetes may only be taking 50% of their prescribed medication. So just having a medication prescribed is no indication that it's actually going to be used. And this, of course, will have an impact on someone's glycemic control. And insulin also is a very tricky medication to manage for many people with type 2 diabetes, but there are a lot of people that need it. And currently in the UK, we've estimated that there's around 500,000 people that are currently insulin treated, and approximately 20% of all people within the UK with type 2 diabetes will be on insulin. However, despite the high numbers, around 30 to 50% of people are not optimized. So they're not achieving target HbA1c levels and not, reducing their risk of microvascular disease. So I would suggest that there are three main areas of priority when thinking about type 2 diabetes and insulin treatment. We have this delay potentially in starting insulin at the right time, and this may be at the individual level, the healthcare professional level, and the system level. And we also have a problem around optimizing insulin initiation. So there's some discussion about the best way to do this, and also there's this a discussion around, how we support people who are already taking insulin and who delivers this support and what is needed. So first of all, I'm going to focus more on the individual factors that might affect whether or not somebody starts insulin. And so this term, psychological insulin resistance, was first used in the 1990s by Leslie and colleagues, but research to quantify this term was mainly conducted in the early 2000s, particularly by Polonsky and colleagues in the US. And it describes people with type 2 diabetes for whom insulin is indicated, but they are unwilling to start it or persist with it. And it's very common, and it affects around 1 in 4 people who actually need to have insulin. It's distinct from a needle phobia. And this is usually linked to negative beliefs around insulin. So negative beliefs can relate to the issues around the injections themselves. So for example, being scared of needles or just taking an injection, they're fearful of the pain. They might be fearful around the side effects of insulin, such as weight gain. So, I don't think insulin causes it, but I don't think it helps. It's harder to lose weight. And hypoglycemia, another of the side effects of insulin. If the blood glucose gets too low, so that's when you faint, that's why I don't want it. And often there are issues to do with self-perception, and it's the end of the road. And these are very, very common issues and beliefs around insulin. So it's possible to tackle this psychological insulin resistance. And we know from the literature that many people who report these sort of negative beliefs around insulin and then start insulin tend to adjust their perceptions of it and become more positive about it. But it is possible to target interventions that directly address these barriers and these often misperceptions around insulin. So to help people accept the treatment in the first place, and perhaps by addressing these factors, we can reduce delay in starting these insulin when it's needed. So we've talked about psychological insulin resistance, which we know is very common, but something else that has not necessarily come to light through some of the qualitative research that's been conducted that is known to affect both onset and progression of type 2 diabetes is depression. So we know that depression is highly prevalent amongst people with type 2 diabetes. It's associated with increased incidence of type 2 diabetes, higher HbA1c, and diabetes complications. So we were wondering, could it be that being depressed means that people are less motivated to take insulin when it's indicated? And so this is what myself and my colleagues, specifically Rebecca Upshur and Khalida Ismail, sought to investigate. So what we did was we followed up a sample of people from diagnosis of type 2 diabetes. We assessed their depression status at baseline, and we followed them up for around 8 years. And what we found was in the depressed group versus the non-depressed group, that people with depression were at the insulin requiring stage that necessitated insulin therapy sooner than the non-depressed group. However, when we adjusted the analyses for other factors, this association went. However, what we also did was we looked to see whether the depressed group actually started insulin sooner within those 8 years. And we did actually find that people who had been depressed at baseline did actually start insulin sooner than the non-depressed group. So it wasn't really what we were expecting to find. So it wasn't that depression was causing people to delay starting insulin with their type 2 diabetes. So it made us think about what other factors we needed to investigate. And so I don't know if you remember back to the other slide that I showed you. So we're now moving on to other factors, not at the individual level, that might influence whether or not somebody starts insulin. So there's this term called clinical inertia. And in this study by Kunti et al., published in 2013, this was a retrospective study of around 80,000 people with type 2 diabetes living in the UK. and they were followed up for a period of around 9 years, and they found that the median time to intensification with insulin for people with an HbA1c of 58 millimole per mole and taking 2 oral agents for diabetes was around 7 years. And what this basically showed was that people with type 2 diabetes are not necessarily being treated according to our current or previous clinical guidance in terms of intensification of therapy. And so this tends to suggest that there is a problem at the health professional level. So why would this be? So why would clinicians maybe not intensify treatment when it's needed? And the reasons clinicians give for not starting people on insulin at the right time are often very similar to the concerns of people with diabetes themselves. And in a systematic review and meta-ethnography of 42 studies looking at individual healthcare professional system level factors to the initiation of injectable therapy, healthcare professional factors contributing to inertia included worries about the negative side effects of insulin, such as hypoglycemia and weight gain, and the psychological barriers were also similar, such as being aware of social stigma for people with diabetes, and also the issue of dependency on other people, which could suggest a failure to identify the problems that contribute to these issues or manage them. And currently I have a PhD student, Shatha Al-Saeed, who's currently researching this topic specifically, but in Saudi Arabia. So this theme of the health professional, there's also, I suppose, above the health professional, we have these system level factors as well. And these are often very difficult to unpick from the health professional factors, and there's often a bit of overlap. And most studies report that healthcare professional factors, but, for example, there might be some issues around sort of management, support and communication. But in this particular systematic review by Kathy Ellis and colleagues that was published in the BMC Family Practice in 2018, healthcare system organisation was identified as potentially important. And what she did was she found that how teams were organised and integrated was essential, and that when general practices and practice nurses were supported by specialist diabetes teams, it improved clinical decision making and improved support for people with type 2 diabetes. And a good example of a study and intervention which considers both the health professional and system level factors to improve insulin initiation at the right time was this study called Stepping Up that was conducted in Australia. And the problem identified within this particular setting was the need to embed insulin initiation within primary care and clinical practice. And this model of care involved diabetes nurses mentoring practice nurse colleagues to initiate insulin at the right time. And overall, we can find that
Kirsty,
there was...
Can I ask you to sum up, please?
Okay. Right, I'm going to move on to optimizing insulin treatment. So we came up with a psychologically enhanced group education program for people with type 2 diabetes starting insulin treatment, which was based on a systematic review and also qualitative interviews. And we tested this in a feasibility RCT. This was a face-to-face intervention, but because of COVID, we had to stop the study, and unfortunately, we weren't able to really finish it properly, apart from to find that the intervention group felt that they were less fearful of insulin because they had more of a psychoeducational intervention compared with the control group. And because of some issues about delivering the face-to-face time, we also found that the landscape had changed within our area, and that group education attendance could be potentially quite low. So we've now we developed this into an app for people starting insulin in the hospital, and we're about to start testing this. So I will finish there, but thank you very, very much for listening.
Thank you, Kirsty. That was excellent. That was a really excellent run through all the reasons why we need to be focusing on this. And I hope everybody and your contribution to this field. So thank you so much. That was an excellent presentation. So whilst Siobhan, our next speaker, is getting her slides up, are there any questions for Kirsty? Please write them in the chat. I think in the interest of time, it's probably prudent to do it. We are having a little bit of chat. Question and answering, so please do ask Kirsty your questions in the chat and then she will answer them, and we will move on to our last but certainly not least speaker, Siobhan O'Connor, who's going to be talking again about type 2 diabetes, but from a very different perspective. So Siobhan, over to you. Thank you.
That's great. Thanks, Jackie. Hopefully everyone can see my slides. Just shout if there's any problems.
Yes, we can.
Great. So yeah, I'm going to present a small research study that we've just finished using a new co-design method that incorporated generative AI tools to create a VR app with people with type 2 diabetes. So I hope this might be of interest to some of you. I'm a senior lecturer in our faculty and I'm a nurse by trade, but I have a background in informatics before I became a nurse. So because I've got a technical and a clinical background, all of my teaching and research is around sort of technology and healthcare, which includes some co-design and artificial intelligence, because they're both important areas of informatics and something that I think nurses need to be good at. So this research study really started because I met a great diabetes nurse specialist called Nicola Mill, where I was working, and she's very research active, and we got chatting and realized that there was some overlap because I'm not a diabetes researcher by trade. I work in digital health, and I had been co-designing a virtual reality app to help people practice mindfulness to reduce chronic pain. And Nicola thought that it could be adapted to help people with diabetes manage the stress that they experience, which is something I'd never really come across myself as a nurse. But it is a well-researched area, and about 30% or so of adults with type 2 diabetes experience diabetes distress for several different reasons. There's the burden of daily self-management and juggling diet, exercise, and medication. Some people worry about the complications of diabetes, like having a hypo or long-term nerve damage, and anxieties about accessing healthcare services because they're not always easy for some people to get to. So, for example, people can experience stigma from healthcare professionals, particularly if they're overweight or obese, which I'm sure is very off-putting if you're trying to get good care. And that stress that people experience is linked to poor self-care, low mood, and increased risk of elevated HbA1c. Diabetes distress also tends to occur more in women, younger people, and non-white and ethnic minority populations, and those with shorter diabetes duration. And obviously, because there's millions of people worldwide with type 2 diabetes, and those numbers are going up all the time, I think it's estimated that there'll be about 500 million by 2040. It's a big problem, and it also affects people with type 1 diabetes. It's just our study focused on type 2. And we're very lucky at King's because we have one of the world leading experts on diabetes distress, Professor Jackie Sturt, in our faculty. So when I moved to work at King's about 18 months ago, I was able to link up with Jackie, and she joined our team for this research study, which was great. So as I said, I've been working with mindfulness colleagues at City University of London on my previous VR research, because mindfulness is a third wave cognitive therapy that comes from Buddhist meditation, and it involves really sort of paying attention to the present moment experiences in a non-judgmental way. So it's very much about personal self-reflection and personal self-awareness. There are various different types of mindfulness programs like MBSR and MBCT, which have lots of scientific evidence behind them showing that they're beneficial for people with different physical and mental health problems. They've also been used quite a bit with people with type 1 and type 2 diabetes, and they do improve psychological outcomes by reducing stress, anxiety, depression, etc. But there's only mixed evidence of their impact on physiological outcomes, so things like HbA1c and blood pressure. Unfortunately, face-to-face mindfulness programs can be difficult for people to access. They're not always widely available in some areas, and they're not always paid for by the health service long-term. So people often have to end up paying for it themselves, which can be expensive. There are some mobile apps available for mindfulness. If you might have come across things like Headspace is a really popular mindfulness app, but systematic reviews have shown that mindfulness apps generally are sort of poorly designed. They lack personalization and feedback for the people that use them, and some of them only show a limited positive effect on different health outcomes. So that we thought by using a virtual reality technology, we might be able to make a better app to help people with diabetes practice mindfulness to reduce this distress they experience. And we got some funding from the Burdett Trust for Nursing to do that last year. So we have a great colleague in our nursing faculty at King's, Professor Glenn Roberts, who developed a widely used co-design process called experience-based co-design. You might have come across it before because it's been around for many years. So we adapted that and integrated generative AI tools into the process, which I'll talk about in a minute. So we call this new co-design process artificial intelligence informed experience-based co-design, which is a bit of a mouthful, or we just call it AI-EBCD for short. Our study protocol is published in BMJ Open, which describes everything in detail, but I'll go through what we did with you now in case you're interested in co-designing a digital mental health intervention. So we used a mixed methods design over 3 phases following the MRC Complex Intervention Framework. So the first phase of co-design concentrated on 2 activities. We started with a review of commercially available VR apps for mindfulness, and we followed some guidelines that colleagues and I developed for reviewing commercially available health apps, because it's slightly different from doing a standard literature review or systematic review. And those guidelines are published in BMJ Open as well. Our VR app review is under peer review, but it is available on the preprint server if you want to get more details. But basically, we found 5 VR apps related to mindfulness, including Headspace, which now has a VR version as well. So a team of about 6 of us, 3 of whom are mindfulness practitioners and mindfulness researchers, downloaded each of the 5 VR apps onto a MetaQuest VR headset to use them. And then we evaluated each VR app using the mobile app rating scale, which is a very widely used and validated scale, because we wanted to understand the different design features and functionality of the existing VR apps to help inform our own co-design process. Then we followed that with interviews with 10 mindfulness practitioners to get their perspectives on mindfulness and practicing in a 3D virtual environment where you are immersed in sound, different visuals, and in some apps you can interact with the virtual landscape as well. So some of the practitioners thought it might work while others didn't, so that it was a bit mixed. And those who thought it might work felt it would only really work for people who are already practicing mindfulness and going to classes, so it could be used as an added extra on top of that. They didn't think it would be a good experience for someone who was brand new to mindfulness, even with, in some form of guided narration from a mindfulness practitioner, which is what we were thinking of doing. But they had lots of useful ideas about how a VR app for mindfulness might work. So reviewing the evidence and speaking to experts is always a good way to start your co-design of a digital intervention. Then for phase 2, this is really the core participatory design work. Once we received ethical approval, we ran 5 workshops over the summer of last year. We started with a focus group with adults with type 2 diabetes to talk to them about diabetes distress and mindfulness and using VR. And that was co-facilitated by an experienced mindfulness practitioner, because we had to teach them a little bit about mindfulness and what it was all about. That was followed by a second focus group where the participants looked at existing VR apps for mindfulness that we had found in phase 1. So we ended up playing them videos and audio clips over Zoom, because it was easier for the group to meet online rather than in person. We had purchased a few MetaQuest VR headsets with the hope of running a workshop face-to-face and getting people to use the headsets and the hand controllers with the apps, but that didn't pan out, unfortunately, because they all wanted to meet online. So we just adapted our approach a little bit, and it still worked reasonably well. Then the third workshop was a creative one where we asked the participants to design their ideal mindfulness experience, and we posted them a range of artistic resources so they could be as creative as they liked at home. And then we just asked them to take photographs of what they created and send those to us. And you can see a drawing that was done by one of the participants on the left of the screen, and she's used lots of lovely colours in a natural environment because that's what she wanted from a mindfulness experience. Then for our 4th workshop, as I mentioned, we used a suite of different generative AI tools, so different AI image, video, audio, and music generators, just to give people more creative freedom with creating digital content that they could generate. And it was lots of fun actually working with them to do that. We used individual think aloud interviews over Zoom, and we signed into each AI tool and got the participants to follow the protocol we'd written. And then there's some free time at the end to kind of play around with each of the generative AI tools. Obviously, for copyright reasons, we couldn't use any of the digital content that they created directly in the VR app, but Gen AI is great for stimulating people's creativity and producing lots of ideas to inform co-design. And our participants, I think, seem to enjoy using them because they're a bit novel and a bit fun. So we got to use several tools, things like we use Pictory, which is an AI image generator, Murph AI for music, and PixArt, and then we downloaded what they created to help inform our analysis and the design of the app. And then the very last workshop was a group prioritization exercise following nominal group technique to get participants to score and rank the top design features, functionality, and content that they wanted in a VR app for mindfulness based on what we discussed in the previous 4 workshops, so that we could really try and get some consensus, because we had a limited budget and time frame to develop a prototype VR app, and we really needed them to pick the most important elements that we could focus on for the software development and user testing in phase 3. So then in the last phase, we handed our software design document over to our development team, and they created the app for us using Unity, which is a VR app development platform. We also used GitHub, which is an online platform that allows software developers to create, store, manage, and share their code. And you can also just use it to project manage the software development lifecycle, so it was really, really helpful to keep track of the whole development process kind of over the winter time of last year. And then as they were developing the different versions of the app, myself and another colleague tested the VR app on a Motorola G350 smartphone, because you needed to have a gyroscope sensor on the smartphone to use all the different features of the VR app. So that means you can basically pan, up, down, left, and right, and see the whole 360-degree landscape. So as you can see on the right, the prototype VR app we developed is a low fidelity version. Angeliki, our mindfulness colleague, provided some mindfulness audio tracks, which we overlaid on a selection of 360 videos that we sourced online for free, because we had limited funding to do the design and development. So you can use the VR app on a smartphone by popping it into a cardboard VR headset, and then that lets you navigate around the virtual environment and choose and listen to a range of mindfulness tracks while being surrounded by different visual environments. So the software development took a little bit longer than we'd originally planned. So we only had about 4 weeks at the end to do some pilot testing with participants who helped co-design the app. We downloaded the VR app onto the Motorola smartphones we purchased and posted those out to participants, along with a cardboard headset and instructions on how to set it all up and use the VR app on a regular basis. We did just a very simple pre and post online survey to measure diabetes distress and quality of life, and there's validated measures for those. And we collected user analytics data that was running in the background of the app, so we could see when, how often, and for how long the participants used the VR app. And then lastly, we just ran some semi-structured interviews with them at the very end to explore their perspectives on using the VR mindfulness app to manage diabetes distress. We're still kind of analysing all that data at the moment. It's been a bit of a slow process, but we're nearly there. But overall, the participants felt that the visualizations, the sounds, and the narration really helped them practice mindfulness a bit more, and they felt that the app increased their focus, awareness, and concentration. And they also found it relatively easy to navigate and use, but they really wanted a lot more personalised content with more feedback on how they were progressing. For example, having a tracker for their mood, and they also wanted mindfulness practices specifically around eating, because that's what they really struggled with the most. And then a couple of them found the VR headset a bit uncomfortable to use. They could only use it for maybe 5 or 10 minutes. And one lady actually swapped the VR headset we sent her for one that her husband had that was better quality. And she found that much easier. So yeah, the moral of the story is don't scrimp on your VR headsets, because the cardboard ones aren't very comfortable to use. So as I said, our results are a bit mixed, and obviously the sample size of the people who use the app is very small. So we need to do more research really to see if the app can really help reduce diabetes distress. But we're in the process of writing up a funding application at the moment to do more co-design, develop a more immersive version of the app focused on mindful eating, which kind of has its own set of mindfulness practices. And then we'd like to run a pilot RCT really to look at the effectiveness of the app and the practicalities of doing a bigger clinical trial. So I just want to say a big thank you to all of our wonderful team who helped with the different aspects of this research along with our funder. And we're looking forward hopefully to working on the next version of the VR app. Just before I finish, I just want to flag up one or two other research projects I'm doing around digital health co-design, because designing technology with different groups of people is not easy to do. I got some funding from the NIHR, which is our main funder in the UK, to develop an online methods toolkit on digital health co-design to help researchers especially, but also clinicians and other people to learn about all the different mindsets, methods, tools and theories that you can use to create health technologies, whether it's software, hardware or a mix of both, with different end user groups and other stakeholders. And alongside that, we're creating an implementation framework to highlight the barriers and facilitators to co-design, because it's not really easy to do really well. So hopefully that website will be fully functional by the end of the year. We have another couple of months to go on the project to populate it fully, but hopefully it'll be a really useful resource if you want to learn more about digital health co-design. And then the very last thing I want to plug before I finish, which isn't directly related to co-design, but just in case anyone is interested, I also run the AI Nurses Network, which is the new clinical research network on artificial intelligence in nursing. And you can use AI tools in co-design, so it is a little bit related. Our website has a suite of resources for nurses, including free training on AI and data science, seed funding that nurses can apply for if they have an idea for AI that they want to get off the ground, and a range of news and events on AI in healthcare. We'll also be running a hackathon on AI and nursing later this year, which should be great fun. And we have a LinkedIn group where we post lots of additional resources on AI, and a YouTube channel where we host our webinars from nurses around the world using AI in their research or clinical practice. So yeah, if you want to keep up to date with what's happening, hopefully that website is useful to you. So that's everything from me. Thank you for listening, especially during a very busy day, and I hope some of that was useful for you. Feel free to drop a message in the chat or drop me an email if you have any questions, and I'm happy to take those.
Thank you, Siobhan. That was excellent, and really brings to light the sort of the art and the science of interventions that appear to be useful for people in relation to their healthcare. I love the idea of people generating their own, using AI to generate their own mindfulness images and resources. There's just time for one question, I think, before I thank you all. And Angela in the chat mentioned whether or not I thought it would be useful to have a similar intervention for another condition. I think sickle cell was mentioned. From your knowledge of the literature, is diabetes at sort of the leading edge of bringing these things together, or is it already happening in other conditions that you're learning from each other?
Yeah, mindfulness has certainly been used across many different chronic conditions, I guess, because people have, in terms of managing symptoms, a lot of the symptoms would be similar across. I haven't come across research on sickle cell, but if I do a quick search, I'm sure it's there. Yeah, it's a very popular, mindfulness is a really popular therapy, and digital forms, I think, are becoming more popular just because they make it more accessible to people, especially where mental health services are being cut in certain countries. And yeah, the digital forms, even though they might cost a little bit of money, I think are a good investment if you want to get daily support with mindfulness practice and mental health issues.
Thank you. Well, there's been some great, thank you to all our speakers. Thank you for participating. There's been some great discussions in the chat. The recording will be available on YouTube, I think. So we'll all have access to that. And I really would like to very much thank Clare and Kirsty and Siobhan for such amazing research and amazing presentations about their research, for all your engagement in the questions. And please get in touch with with our presenters if you have follow-up questions. Remember the upcoming seminars next month around the TORCH programme and the PhD programme, and hope to see many of you in June for our next presentation of research. So have a wonderful rest of your day, and thank you very much. Goodbye.